Recording in progress.
Absolutely brutal. How would be like the people that are struggling to get
Recording in progress.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It is my great honor and pleasure today to have Dr. Amr Abu Al-Ila. He is ICU consultant in United Arab Emirates and he's former professor of critical care at Alexandria University. Really today will be an extraordinary lead into the hemodynamic monitoring which is a pivotal function for all anesthesiologist, critical care physician, intensivist, emergency medicine physician, and all who are interested in caring in his critical situation. Thank you, Dr. Amr, for accepting our invitation. And really, it is a very suitable day to celebrate the starting of the 4th year of the online program of ISAC. This is the start of the 4th year. Thank you to have you on our last session in 2024, and we are inviting you to be with us along all the effort. The floor for you, Ahmed.
Good evening, everybody. I would like to thank all attendees for the attendance today. Hemodynamic monitoring is a cornerstone in the critical care practice. I think it's the patient is admitted to the ICU. One of the criteria one of the rationale to admit the patient in the ICU for closing hemodynamic monitoring. It's a very important, very basic, but at the same time, it's very important for all intensivists and all physicians working in the ICU to have a knowledge about the how to monitor the patient, the vital signs, how to be very close to the patient and to get the data which it reflect the patient condition, improving the tissue perfusion and the oxygenation. All these issues, it will be covered today by our professor, Dr. Amr Abu Al-Ila. He is a consultant critical care and also he's a professor of critical care in Alexandria University. Inshallah, I hope all of you will get a benefit and would get the knowledge about the hemodynamic monitoring. تفضل Dr. Amr, you can start now.
Assalamu alaikum wa rahmatullah. Good evening, everyone. At the beginning, I would like first to express my great thanks to Dr. Professor Safa Hilal for giving me this opportunity to chair in the Egyptian Society of Anesthesiology, Anesthesia and Acute Care. And also I want to express my great thanks for Dr. Ahmed Fatin for moderating this session. As you mentioned, Dr. Ahmed, the hemodynamic monitoring is a cornerstone in the practice of ICU, anesthesia, and ER doctors, and everyone working in this field should master the hemodynamic monitoring. It's very critical and crucial topic. Today, I would like to cover the hemodynamic monitoring. It will be a little bit a long session, I think, because there is a lot of points to be covered. So my objectives today will be a review of the basic concept of hemodynamic monitoring and management, physiology of oxygen balance, the delivery, uptake, and utilization. What are the determinants of oxygen delivery, factors to optimize oxygen delivery and reduce oxygen consumption, physiology of cardiac output and its variable. What is the role of hemodynamic monitoring and what to monitor, why you should monitor and how to monitor. And then we'll talk about the concept of fluid responsiveness. We'll talk about the evidence-based review. What is the guidelines? What the guidelines tell us about this topic. I will try to minimize slides related to the evidence base. I will try to be more towards a practical session to like explain what is the application of different tools of hemodynamic monitoring, how to apply it, how to take the measurement, how to interpret the data. I will minimize. I will have only few slides talking about the guidelines and the study. I am trying to get it more practical session. Then we'll talk about the application of the pulse contour technology or the PICO monitor, how we can apply it. Echo, role of echo in measuring or assessment of the cardiac output. And finally, I will go for a little bit long topic, or the last station will be the different tests for fluid responsiveness. There is a lot of tests, but I will focus about the measurement of the IVC assessment by ultrasound, respiratory variation of IVC, the passive leg raising test, and index respiratory occlusion test. Every objective of these objectives can be a separate lecture. That's why I will be focused and to the point. I will try to summarize and highlight the important topics or important points in each of these objectives. So initially, this guy is Edward Fluger. This is a German scientist in physiology. In 1872, he mentioned that the cardiorespiratory system fulfill the physiological task of ensuring cellular oxygen supply. This is an old statement, more than 150 years. He mentioned this statement, but still it's very valid and constitutes the cornerstone of hemodynamic monitoring. It's very important to understand this concept. And as you see here, we are talking about the hemodynamic. We are thinking all the time about the heart and the lung as a master or major organ. It's of course a master and major organ, but the real master here is the cell. The cell is the master part, and the lung as a manufacturer of the oxygen, and the heart as a main vehicle to deliver the oxygen to the peripheral cell. Are very vital, but again, the end user is the cell. The cell is the master of this game of hemodynamic, and oxygen is the target. We are talking all the time about the blood pressure, the cardiac output, but you should keep in mind that the cell is the end organ, it's the end user, and the oxygen is our target, how to deliver enough oxygen to the cells. And I will explain in the next slide what is the importance of this point. Second important point, which is the hemodynamic from each name, it's a very dynamic process. We are monitoring the patient. We are checking many measurements. Of course, we'll talk about what are we monitoring. And then we are trying to do certain intervention to optimize the oxygen supply, the oxygen consumption, and try to close the gap if there is a gap between the supply and the consumption. We are giving certain therapy, and we are checking what is the response of what we give, what are the effects and side effects, and we are checking again, reassessing, monitoring, and then checking and giving therapy and so on. So it's a very dynamic process, and all the time we have to check and recheck everything because it's changing from one time to one, from 1 minute to 1 minute, or from 1 hour to 1 hour. So it's very dynamic, and the intensivist, anesthesiologist, ER doctor should be aware about the sudden changes which happen in the patient and should be aware to go for the active intervention in the proper time. Physiology of oxygen delivery. Oxygen delivery, by definition, it's amount of oxygen delivered to the tissue. This is dependent on the arterial oxygen content and the cardiac output. In general, in healthy adult subject, it's about 1,000 ml or 1 liter per minute. And if you do a rough calculation, you know, of course, that the cardiac output is about 5 liters per minute. So the oxygen content, it's about 1/5 the amount of the cardiac output. 5 liters of blood containing 1 liter of oxygen. And I will tell you in the next slide why from where we get this number. Oxygen carrying capacity of blood. The oxygen in the blood, most of the oxygen, up to 98%, is carried in combination with hemoglobin. Only 2 to 3% are dissolved in plasma. So the oxygen content is relying mainly on the amount of hemoglobin or the amount of oxygen carried in the hemoglobin. And you should know that 1 gram of hemoglobin is able to bind 1.34 ml of oxygen. So if the hemoglobin is totally saturated, 100% saturated, and we are considering a normal person with a hemoglobin of 15 gram per deciliter, it means that the content in deciliter, which is 100 ml of blood, which will be equal to around 20 ml of oxygen based on this equation. So again, it's, as I told you, it's 1/5 of the volume. 100 ml of oxygen of blood is containing 20 ml of oxygen based on a normal physiological data, which is hemoglobin of 15 and oxygen saturation, which is approaching 100%. So from this slide, we can understand now that the oxygen content is dependent on how much hemoglobin and how much oxygen saturation. And of course, the oxygen content is not the only equation. It's only part of the equation. So if we will go for to summarize this point about the determinant of oxygen delivery to the peripheral cells, we'll find the oxygen content, which is dependent on the saturation and also the hemoglobin. And of course, this amount will be multiplied, the oxygen content multiplied by the cardiac output. So it's very important fact when we are talking about this game of hemodynamics, you should remember all the time that we have on this game 3 players. We have the hemoglobin, the saturation, and the cardiac output. It's not only the cardiac output, not only the blood pressure, not only the stroke volume, because most of the time when we are talking about the hemodynamic, everyone is thinking about those variables, how much is blood pressure, how much is the cardiac output. But don't forget, if you have a hemoglobin of 8 or hemoglobin of 7 for a shocked patient, you will not be able to improve his oxygen delivery. Even if you maximize the cardiac output, you should keep in mind that you should maximize or optimize the hemoglobin. You should optimize the saturation as well if you have a problem in the oxygenation to get the maximum oxygen delivery. So remember all the time when we're struggling to increase the cardiac output by 10 or 15% with giving fluids and vasopressor and inotropes, that just increasing the hemoglobin from 8 grams to 10 grams, it will help you to increase the oxygen delivery by around 20 or 25%. So don't forget when you are playing this game of hemodynamic that we have 3 important variables, which are the saturation, the hemoglobin, and the cardiac output. If you have inadequate oxygen delivery, which represent, of course, imbalance relative to the need, because all the time we're talking about the balance between the oxygen delivered to the peripheral cell and the oxygen consumption. If we have a balance between the consumption and delivery, we have no problem. If we start to have imbalance, it means that the consumption or the supply, it's not matching with the demand, with the oxygen delivery. So we'll have a problem of tissue hypoxia, or what we call the shock state. The shock state is imbalance between the oxygen delivered to the peripheral tissue and oxygen to be consumed. And at this stage, you will have the shock. And we can conclude also, we are talking all the time about the hypovolemic, the cardiogenic, the septic shock. But keep in mind also that if it's related, as we mentioned, to the oxygen delivery, you have also, I like to call it anemic shock and hypoxemic shock. If you have a problem in the hemoglobin or a problem in the oxygen saturation, this can lead to shock, imbalance of oxygen demand and supply. This is can be also 2 forms of shock, the anemic and hypoxemic shock. Part of the equation, of course, is the oxygen uptake. How much oxygen is in normal situation is taken by the peripheral cells. Of course, the oxygen uptake is the difference between the oxygen delivered in the arterial system and oxygen returned to the lung in mixed venous blood. In the mixed venous oxygen, it's around 760 ml per minute. We mentioned before that in the arterial system, every minute we will have a delivery of 1000 ml per minute of oxygen. In the venous side, we have 760 ml. It means that around 250 ml per minute, which is almost 25% of the oxygen, is uptaken by the peripheral tissue for consumption. This is the normal consumption. If we have a problem in this equation, we will have the oxygen debt when the uptake exceeds the delivery, as occur in shock, and severity, of course, can be monitored by rising blood lactate or anaerobic metabolism, and we'll come to this slide to explain why the blood lactate will be high if there is no enough oxygen. So if I ask you now, what is the normal oxygen saturation and what is the normal arterial and venous saturation? Can anyone answer this question, please? You know the arterial saturation is 100. What are you expecting the venous saturation to be? Any one volunteer want to answer?
70.
Yes, it should be around 70 to 75% because, as we mentioned, there is 25% already uptake by the peripheral tissue. So we are expecting that the venous saturation should be 75 because 25% is already taken by the peripheral tissue. This is in normal physiology, 25% the uptake. This is the normal physiology. If you have a problem in the oxygen delivery, the tissue can accommodate also to uptake or to extract more oxygen. What is the maximum uptake? Anyone know what is the maximum uptake by the peripheral cells?
40.
It can be up to 50%. The peripheral cells or peripheral tissue can extract up to 50% of the oxygen delivered. This is the maximum delivery. I will show you in the next graph a very important relation between the oxygen consumption, oxygen extraction, and oxygen delivery. If you have a decrease in the oxygen here, if you have a decrease in the oxygen supply or oxygen delivery, initially the oxygen consumption will be stable. You can see the line here is stable because the oxygen extraction ratio will increase from the normal 25 up to the maximum here, which is the 50%. At this stage, we will have an independent area of oxygen delivery. The consumption here will be independent of the delivery. So whatever the delivery is low, the peripheral tissue will be able to extract enough oxygen until the peripheral tissue reach the maximum extraction, which is, as we mentioned, around 50%. At this stage, the body will not be able to compensate anymore. We will go to the more dangerous area, which is the delivery-dependent area. Here we can see that with the stability of the oxygen extraction to the maximum, any drop in the oxygen supply or oxygen delivery will be associated with a drop also in the oxygen consumption. And this is the area of the delivery-dependent area, which is the area we don't like to reach it in our patient. So initially, the oxygen extraction will increase to an extent, to the maximum extent of 50%, and then we start to have the tissue hypoxia or the shock stage. This is an important part of the physiology you should understand. Why we need the oxygen in the cell? We have the oxygen, of course, in the cell. Why we need it? The main fuel or the main substrate for energy in the cell is the glucose. And the main reaction in the cell to do the metabolism is the glycolysis reaction. Oxygen and glucose and glycolysis reaction. So one question is, does the glycolysis is requiring oxygen? This is yes or no question. Anyone know?
Yes.
Glycolysis reaction? Actually, the answer is no. The glycolysis reaction itself does not require oxygen, but the glycolysis is the first step of the equation, because we will see now that the glycolysis is the first step of the equation. And then in the cell, in the mitochondria, there is another important reaction, which is the oxidative phosphorylation. So in the presence of oxygen, in the aerobic condition, the oxygen with the glucose, we will have the glycolysis reaction. This will produce ATP, small amount of ATP, only 2 ATP and pyruvic acid. And the pyruvic acid will go to the second reaction, which is the oxidative phosphorylation. This is the reaction which needs the oxygen. So each pyruvic acid is producing 34 molecule or units of ATP. So the total 36 ATP. In the absence of oxygen, the anaerobic metabolism here, the glycolysis will happen is the same because the glycolysis is not dependent on the oxygen, producing a very small amount of energy, only 2 ATP for every glucose, and producing pyruvic acid. But unfortunately, the pyruvic acid in the absence of oxygen will not go to the oxidative phosphorylation, and the reaction will stop here. And the pyruvic acid, of course, will be metabolized to another agent, which is the lactic acid. Pyruvic acid will be converted to lactic acid. And from here, you can understand why in shock or in anaerobic condition, the lactic acid is high. This is as a production of the conversion of pyruvic acid to the lactic acid in the absence of the oxygen. So we are faced here with two problems. In the absence of oxygen, that we have a very low production of energy. Instead of 36, only 2 ATP instead of 36, which is around 50% of the normal amount of ATP to be produced. And we'll have another problem, which is the acidosis, the lactic acidosis. Anaerobic metabolism will lead to inadequate energy production, metabolic failure. And again, here the anaerobic metabolism will lead to lactic acid production, metabolic acidosis. Both these two problems, the acidosis and metabolic failure, will lead to the cell death. And this is, of course, the reaction which doesn't like to happen for our patient, who every effort should be done to stop the process before reaching this stage. This is a very important graph. There is a lot of studies like this comparing the probability of survival compared to the level of lactate. And you can see with normal lactate level 0 to 2, the survival is around 100%. But with further increase in the lactate level, you see the mortality is approaching 0 or maybe less than 5% when the lactate will reach 10. That's why there is a great correlation between the level of lactate and the survival in shock. And it's one of the important laboratory measures we are using, the lactate, to measure the progress of shock and also the response to treatment. If you are giving a treatment for the shocked patient and the lactate is reduced or in the trend of reduction, so you are in the right way, the lactate is coming down, so you are managing your patient properly. If the lactate is still rising more and more, so we have a problem in the management, or the patient is not on the right direction. So if you will compare now between the lactate as one of the laboratory parameters to monitor the patient with shock and the central venous saturation, we mentioned that the central venous saturation, it's 75% in a normal person. What if the central venous saturation will drop to 60 or 50? And what with the of the lactate is increasing? Can anyone comment what is the difference between the significance of change in the central or venous saturation and the lactate? Anyone have a comment on this point? Anyway, the drop in central venous saturation, it means that the patient, there is impending shock, because this means that the oxygen delivery is increasing. That's why the venous saturation is dropping, but still the lactate is normal at this stage, because the patient physiology is still, the patient body is able to compensate for the reduction in the oxygen delivery by increasing the oxygen extraction, but the patient not starting the phase of shock. But when the oxygen uptake will reach the maximum and the patient start to have the anaerobic metabolism, the lactate start to rise. So the drop in the central venous saturation is an impending sign of shock, while the increase in the lactate is a sign of shock already happened. This is an alarming sign, the central venous saturation, which is supposed to happen before the increase of lactate. This is a very important parameters to be monitored, and it's important to understand the significance of each one. So back to this equation to see how you can manipulate, how you can handle, or how to can optimize the hemodynamic status or hemodynamic profile of the patient based on the 3 variables we mentioned before, the 3 players, the saturation, hemoglobin, and the cardiac output. If we will go to this is the fourth station or fourth objective, how to optimize the hemodynamic status. We have, of course, the hemoglobin, and it's well known how you can improve the hemoglobin. If the hemoglobin is low, we can give blood transfusion, RBC transfusion. And I'm sure that all of you are aware about the important study of restrictive versus liberal blood transfusion in ICU. And all of us know also that keeping the target hemoglobin of 7 compared to 9 has a better outcome. 7 is better than 9. But unfortunately, this is not applied in shock. If you have a shocked patient, of course, you cannot go with a target of 7. You should go with a target of 9, hemoglobin of 9 or 10 at least, to maintain a good oxygen delivery. As you mentioned, the hemoglobin is very important determinant of the oxygen delivery, and increasing the hemoglobin from 7 or 7.5 to 9 or 10, this will be associated with around 25% improvement in the oxygen delivery. So every effort should be done to keep the hemoglobin in shocked patient around 9 to 10. Again, saturation, if you have a problem in saturation, it's very easy to control the saturation by starting mechanical ventilation or improving the oxygen to keep the saturation all the time between 99 to 100, again, to optimize the oxygen delivery. And of course, the third party or the third player in the game is the cardiac output. And we'll talk later on in this lecture how to optimize the cardiac output, of course, by giving fluid volume, catecholamines, either inotropes or vasopressor. This is the way to optimize our patient regarding the hemodynamic profile. So our target, provision of good oxygen, normalization of feeling pressure, cardiac output, maintain hemoglobin 10, maintain saturation around 100%. So what about reduction of metabolic demand? As we mentioned, the shock happen from imbalance between the oxygen demand and oxygen supply. If you are not able to maximize, or already the oxygen delivery is maximized, is it possible to reduce the oxygen consumption? Is there any way to reduce the metabolic demand of the cells? Anyone have a suggestion how we can reduce the metabolic demands?
Mechanical ventilation, sedation, muscle relaxant.
Excellent. This is these parameters are applied to reduce the oxygen consumption or the oxygen usage in the cell. Of course, this is comparison between sedation. Using heavy sedation compared to moderate and light sedation, you can see that the oxygen consumption here is reduced significantly. Again, with usage of the muscle relaxant paralysis, there is 25% reduction in the oxygen consumption while using the muscle relaxant compared to the limb with no muscle relaxant. Cooling, we are not talking too much about hypothermia, but at least to keep the normal temperature, because if you have a patient like in sepsis or septic shock and they have fever, this is a comparison between patients who have a fever of 39 with compared to normal temperature of 37, and you can see there is almost 50% increase in the oxygen consumption due to the fever. So cooling or normalization of the temperature is very important tool, of course, also to reduce oxygen consumption. The last point is mechanical ventilation. Of course, mechanical ventilation will reduce the oxygen consumption, especially in shock. This is comparison of the oxygen delivery or oxygen consumption by respiratory muscle and diaphragm in normal person, which is around 55%. During stress or surgery, it's reaching up to 10%, in COPD up to 15%, pulmonary edema up to 25%. Let's imagine that during shock, due to a physiological derangement, that the oxygen delivery to the respiratory muscle will reach up to 50%. So it's very important, if you can sedate your patient and start mechanical ventilation, you will divert all the oxygen consumption in the respiratory muscle to go to more vital organs like the brain, the heart, and kidneys, and you are saving too much energy and too much oxygen consumption. That's why, if you remember the classification of respiratory failure, we are talking about type 1 and type 2 hypoxemic and hypercapnic respiratory failure. Remember that the type 4 respiratory failure is the shock. Shock per se is the one of respiratory failure categories, and patient, I'm talking of course about patient with profound shock who need really support by mechanical ventilation, which is one of the tools to reduce the oxygen consumption and to maintain the balance between the oxygen delivery and the oxygen consumption. So to summarize the last part, the part we finished already from this presentation, some important key points. hemodynamic monitoring, as we mentioned, is a very dynamic process depending on the balance between oxygen delivery and oxygen consumption. Determinant of oxygen delivery are the three players, as we mentioned: the cardiac output, oxygen saturation, and hemoglobin. All should be optimized to maintain the maximum oxygen delivery. Measure to reduce the oxygen consumption should be kept in mind also in shock, like induction of mechanical ventilation, starting sedation, muscle relaxant if needed, and cooling or control of temperature to avoid hyperthermia. This is a very important part of the physiology of the hemodynamic profile of critically ill patient. Now we'll go to another station, which is the cardiovascular system physiological consideration. What are the physiology of the cardiovascular system? You know that the cardiac output or adequate cardiac output rely or depends upon three factors, which are the preload, which is the venous system, or the filling pressure, or the tank, what we call the tank. And we have the heart, the cardiac contractility. And we have the afterload, which is the arterial system, of course. This is the three components which constitute the physiology or the optimization of the blood flow or the maximization or optimization of the cardiac output. This is very important equation also. You should keep in mind that the blood pressure, from physics, we know that any pressure is equal flow times resistance. The flow here is the cardiac output, and the resistance is the systemic vascular resistance, which is the resistance, of course, in the arterial system. So blood pressure equals the systemic vascular resistance multiplied by the cardiac output. What are the common intervention? What are the treatment lines? How we can improve or optimize the cardiac output? We have what we call the VIP approach. V for volume, giving IV fluid. I for inotropes, dobutamine. P for pressors, norepinephrine or vasopressin or whatever. So, as you see from this slide, it seems it's not very complicated. We have three factors, which is the preload, the contractility, afterload, and we have three treatment lines, which are the volume, the inotropes, and the pressor. Actually, the situation is not as simple as that, because most of the time, we are not able, without adequate hemodynamic monitoring, to identify what are the real actual problem of the patient, and we are not able also to identify what is the optimum treatment to be given at what time, because it's a very dynamic. Maybe now we need to give fluid. After 10 minutes, the patient is already full or even congested, and you should start norepinephrine. So it's a very dynamic process and need a good experience to understand the physiology and to use the available tools to reach what is the proper situation of the patient and to decide what is the proper intervention at the same time. A new station, what is the role of monitoring? What are we targeting from monitoring? We are monitoring the patient to reach a diagnosis. If we have a patient of shock, we should determine what is the cause of shock, what is the pathophysiology of shock. It is septic, cardiogenic, it is distributive, it is hypovolemic shock. And by the way, the most common type of shock in ICU patient, it's a mixed shock, because the situation are very complicated in ICU. Most of the patient have a mixed shock, and mostly it's septic and cardiogenic. Septic patient, after a while, they will have also myocardial suppression. And while the initial pathology can be septic shock, after a while, the patient will have a myocardial suppression. And it's somewhat difficult to determine if the patient really need to give more fluid or to start to give inotropes. It's not easy to decide which is the optimum treatment. The role of monitoring also in directing us to the optimum intervention. As I mentioned, what treatment to be given at what time. Maybe I can give fluid now. After 10-15 minutes, I am obliged to give another line to maybe to give inotropes or vasopressor and so on. We should assess the response to intervention. What is the effect of our intervention? Is it really improving the hemodynamic status or no? And what are the side effects? You should remember that every medication or every intervention we are doing, there is an effect, beneficial effect, and there is a cost. We have to pay the cost in the form of side effects. We should monitor the effect of what we are giving fluid. Is it okay for the hemodynamic? Is it affecting the respiration, the oxygenation, and so on? And we should all the time assess and reassess every time to know if the patient is improving or we still need to change our strategy of management. What to monitor? It's very important part. What are we are going to monitor? What are the parameters to monitor? Basically, we are monitoring, as we remember from the previous slide, we have the preload, we have the contractility, the heart, we have the afterload, and we have another important point, which is the fluid status in the lung. When you are giving fluid, is it okay, or the lung start to be flooded of fluid? We cannot give any more fluid. For the preload, or let's be more precise, we are talking now in this era about the fluid responsiveness, not the fluid status. Fluid status, we are talking about static parameters, while in the fluid responsiveness, we'll come to this in the next few slides. What is the fluid responsiveness? So we have many tests to check for fluid responsive. We have fluid challenge, many fluid challenge, passive leg raising test, and expiratory occlusion test. We have the change ultrasound respiratory variation in the inferior vena cava. We have the PICO monitor. We have a very important parameters to be checked: the stroke volume variation, pulse pressure variation. All those parameters are a parameter to check or assess if the patient is fluid responsive or no. And we will talk about this test in details. For the contractility, we are checking the stroke volume, we are checking the cardiac output, or by echo, you can check what we call the VTI. We'll explain it in details, what is the VTI and how to measure it. So basically, to check for this, we need the echo, or also you can rely on the PICO monitor, and in the PICO monitor, we can assess the cardiac output by two different techniques, which is a pulse contour and thermodilution. We'll explain this also. And for the afterload, to check the systemic vascular resistance, we have two main parameters, or two monitoring tools, which is the PICO monitor again, or the Swan-Ganz. And as you know, the Swan-Ganz is not widely used nowadays because of many data regarding using the Swan-Ganz and increasing mortality. Even the experience of the staff now with using the Swan-Ganz is declining, and it's not used anymore as a routine practice in our ICUs. Lastly, the fluid status. We have also to check the fluid status if the lung is flooded or no. We have the ultrasound, and we have again the PICO monitor. PICO monitor also can assess the extravascular lung water and can tell us if the lung start to be congested or overloaded with fluid or no. So as you see from these slides, that the PICO monitor is present in all data. PICO monitor for preload, fluid responsiveness, PICO monitor for the cardiac output, for the afterload, systemic vascular resistance, and also for the fluid status. That's why I'm considering the PICO is one of the revolution in the hemodynamic management or hemodynamic monitoring in the last years. Using the PICO monitor is, of course, I will talk in details about the limitation, and there is some limitation, of course, for every tool has its limitation. But the PICO monitor represent one of the important and easy tool for hemodynamic monitoring, and I think it should be present in every ICU. It's not very expensive, by the way. The PICO monitor, maybe the expense will come from the using special caster. It's somewhat maybe expensive, but still you should be aware about the PICO monitor and its uses, and I will talk about this in the next stations. Now I want to emphasize before going to the PICO about the concept of fluid responsive. What does it mean? We have to answer 5 questions here. What is the definition of fluid responsive? How much response to say that the patient is fluid responsive or no? Why we should measure the fluid responsiveness, how to do, and this is the last station, how to do the different tests I just mentioned for fluid responsiveness. And also, I want to talk about the fluid responsive versus the fluid tolerance. This is the important part. Basically, the definition, it's easy. A definition of the fluid responsive is the ability of the cardiovascular system to increase the cardiac output in response to increase the venous return. It's very simple. You are giving the patient fluids. You are expecting that the patient will respond by increasing the cardiac output. This is the normal expected response, but this is not happening, of course, in all patients. In some patients, this will happen. Some patients, this will not happen. And this is the role of fluid responsiveness to tell us before giving the fluid if this patient will respond to the fluid by increasing the cardiac output or not. How much is the expected or accepted response? If the cardiac output is increasing by 15% or more, while giving fluid, we can categorize this patient as a fluid responder. If the cardiac output is, let's say, is 3 liters per minute and it's increased to 3.5, this is a significant increase, more than 15%. If it's a 3 liter increase to 3.1 or 3.2, it's less than 10%. It's minimal increase, which is not significant, and this patient is not considered as a fluid responsive. Why we should monitor the fluid responsiveness? It's very important because I will show you, there is many studies, but for the sake of time, I will not discuss too much. Just I want to give you a hint about this slide. This is comparison between the river, the early good directed therapy for septic shock, and all of you, especially the senior staff, know the river was released in 2001, the river studied early goal directed protocol, and all of us were using this protocol, giving too much fluid, early fluid, target CVP more than 8, giving too much fluid just to correct or to treat the septic shock. In 2013, there was 3 important trials, the process arise and another trial for a revision of the river trial. And you see here, they are giving less fluids compared to the river. Here in the river trial or the early goal directed therapy, in the first 6 hours, 5 liters of fluid was given compared to 2.8 here. And after 72 hours, the patient in the river trial, they got up to 13 liters versus 7.2. And you can see here that the mortality in the process trial and other trial, it's almost less than half the mortality, 21 versus 44 in the early goal directed therapy. It means that giving too much fluid to the patient, it's not a good approach. This is a wrong approach, and this is increasing the mortality. And you should be very cautious deciding whether to give fluid or no. We should know the patient will be a really fluid responder or no. The result of this study that they concluded that liberal fluid resuscitation strategy, CVP more than 8, and use of normal saline as the main fluid of resuscitation are the deadly trio, the triad of death. Saline, high CVP, liberal fluid resuscitation are the triad of death, increasing the mortality. And this is, of course, not accepted to give fluid and fluid and fluid without checking if the patient really will improve or will respond to this fluid or no. And I will come to, in the next slide, to two important also graphs and study explaining the importance of fluid responsiveness. How to do, this is the last station, how to do and how to check fluid responsiveness. We will talk to this later on. But just I want to emphasize about the last point, which is the fluid responsiveness versus the fluid tolerance. And I'm not sure if some of you or all of you attended 2 weeks ago, there was an excellent webinar by Professor Manuel Brain and Professor Xavier Monet. They are talking about the fluid overload syndrome and the fluid unresponsiveness. This is very important, really, because I want to emphasize one point here, that the patient can be fluid responsive, but you should also understand if the patient is tolerant to fluid or no. Yani not all patients who are fluid responsive should receive fluid, because the patient can be a fluid responsive and the cardiac output can be improved. But again, patient can be intolerant to more fluid because the lung is too much flooded, congested, and giving more fluid can improve the hemodynamic status, but it will deteriorate the lung condition, and it can deteriorate the oxygenation. And as we mentioned at the beginning of the physiological considerations, that the oxygen saturation, of course, is one of our player. It's one important determinant of oxygen delivery. We cannot improve the cardiac output while deteriorating the oxygen saturation. So we should be balanced, and you should understand that everything in life and everything in medicine, that we are getting any benefit from anything, you are paying a cost. And the cost of giving IV fluid is the deterioration of oxygenation and deterioration of the lung condition. So you should be aware while deciding to give the patient fluid. Yes, you should answer the question if the patient is fluid responsive or not. This is initially, but also you should be clear about this point. If the patient is tolerant to fluid or the patient is not tolerant, he will deteriorate if you will give him more fluid. And this is sometimes a tough clinical decision and should be based on many different tools to assess the patient from many aspects. Continuation of what we mentioned, this is important curve. You maybe remember it from the medical school. We learned a long time ago in the medical school about the Frank-Starling relationship. And it's very simple that the preload, giving more fluid or increasing the preload, should be associated with an increase of the stroke volume. This is what we learned in the physiology, in the cardiovascular physiology, until a certain extent where the maximum stretch of the cardiac muscle will be reached. After that time, if you give more volume, the heart will be more stretched, and actually the stroke volume will not improve. Even at the stage here, the steep part of the curve, you will see that the stroke volume even is reduced by increasing the preload. The stroke volume will be reduced or deterioration. And you can understand that the target area here to give the preload or to give volume to improve the stroke volume is not like this, because this is with normal contractility. If we have impaired contractility, which is the situation in many of our patients, the target area will be much more narrower, and you will go very easy from this safe area to unsafe area. Here we can give fluids and the patient can deteriorate more. So it's very important here to decide before giving the fluid if the patient will really respond or no, or if the patient is safe to receive more fluid or no. This is very important consideration to remember about this important physiological fact of the Frank-Starling law. Preload optimization, as I mentioned, it's not an easy task. It's not a magic ball decision. We should have good tools to decide how to do it. And this is comparison between some of the static versus the dynamic parameters for fluid responsiveness. Before we are using the static parameter like the CVP, pulmonary artery occlusion pressure, which was measured by the pulmonary artery or Swan-Ganz catheter. Some of the echo measurement, like the right ventricular end diastolic and left ventricular end diastolic volume, these are taken by echo, this measurement. The IVC diameter, we're talking about the IVC. You should understand also here that the IVC diameter is one of the static parameter, while the IVC respiratory variation or distensibility, this is one of the dynamic parameters. What are the dynamic parameters? Passive leg raising test and expiratory occlusion, stroke volume variation, pulse pressure variation, plethysmographic variability index, the velocity time integral, the VTI by echo, IVC distensibility, and we'll discuss most of the dynamic fluid responsiveness measures now after a while. Just this is an important study. It's not new. It's in 2008. This is a very nice comparison between the responder and non-responder to fluid administration using the CVP. And they categorize the patient as a responder or non-responder, as you know from the definition, by improvement in the cardiac output. There is a cardiac output monitor here, and they saw how much the group of patient here, the patient who respond to the fluid and the non-responder, and they check the CVP. What is very striking here that we have a patient with a very high CVP reaching up to 15 or 16, and those patients are a responder. Despite they have a high CVP, they are responder to fluid, and they are increasing the cardiac output more than 15% while giving fluids. On the other hand, with a very low CVP here, up to 0, there is some people who are non-responder. People with CVP of 0 are very happy, very confident to give them fluid. Again, they are non-responders. The cardiac output did not improve. This is very clear demonstration here that the CVP is not a good tool at all, with all respect of people who are still believing on the CVP. It's not a good tool to decide if the patient will be a fluid responsive, or to decide to give a fluid because the CVP or 0 or 2 or 4, or stop giving fluid because the CVP is 10 or 12. It's not a good measure to decide to give fluids or no. And again, even with the pulmonary artery occlusion pressure, you can see the same. There is very high readings in the responder group and very low reading in the non-responder. So using this static parameter, cardiac feeling pressure, to decide about the hemodynamic response to volume challenge is not a good tool. It's like flipping the coin. We have only 50% possibility or probability of improvement or response, and 50% of non-response. And of course, this is not the proper way to manage our patient in ICU. We should have more accurate tools to decide whether to give fluid or not. Objective number 8 or station number 8, this is guidelines, and this is comparison between the guidelines of consensus on circulatory shock and hemodynamic monitoring task force of the European Society of Intensive Care, which was published by Maurizio Cicconi and others in 2014, compared to the previous guidelines in 2007. And they mentioned here clearly they are recommending using dynamic over static variables to predict fluid responsiveness. And also the second point is to, when the decision of fluid administration is made, we recommend to perform a fluid challenge unless in cases of obvious hypovolemia. And also they recommend to fluid management that should be titrated carefully, especially in the presence of elevated intravascular filling pressure. The most important statement here that the recommendations, the guidelines went with using dynamic over static variables. The CVP, Swan-Ganz, IVC diameter are not enough parameters to decide if you can give fluid or no. And another key point of this presentation, that the advanced hemodynamic monitoring, fluid responsiveness using dynamic rather static parameters, either a clinical test or echo or ultrasound or pico or whatever, but you should rely on a dynamic measurement or tools to decide whether to give fluid or not. This is a very important message. Now I will go to another important station, which is the PICO monitor. As we mentioned, I will start with the PICO monitor because maybe this was the only tool which can give us a response to or answer to all the hemodynamic parameters we want to check: the fluid responsiveness, the preload, the contractility, the afterload, systemic vascular resistance, and the lung condition or the fluid status. The PICO monitor basically consists of two different techniques or two different technology, which are the pulse contour analysis, arterial waveform analysis, or the pulse contour analysis, and the transpulmonary thermodilution. The idea of transpulmonary thermodilution, it's not new, of course. If you are a little bit from the senior or old generation, you will be aware about the Swan-Ganz or pulmonary artery caster. We are using the same principle of the transpulmonary thermodilution. In the Swan-Ganz caster, we are using a caster inserted like a central line from a jugular or subclavian vein, and you are injecting cold saline in a degree of 40 degrees centigrade, and you are injecting from the central line, and at the same catheter, the Swan-Ganz caster reaching to the pulmonary artery, we will have a small thermostat to detect the change in temperature, and from this change, the monitor is creating automatically a curve like this to determine what is the amount of cardiac output based on the change of the of temperature between the blood and the injected cold saline. Here, the same idea is applied in the thermodilution with the PICO monitor, but the difference that we have here a central line and we have an arterial, special arterial line, and the thermostat here is present in the arterial line, the femoral artery. So we are injecting the cold saline from the central line, and the arterial line is here measuring the temperature, and this arterial line is connected to the monitor through a certain calibration to have two functions, the thermodilution and the arterial pulse contour analysis. And just worth mentioning that this curve, which is derived from the thermodilution, it's the smaller the curve here, if the curve is small, the area under the curve is small, it means the cardiac output is high. The bigger curve is associated with low cardiac output. This is against what most people will think. If the curve is big, the cardiac output is big. No, it's the reverse. The small curve is associated with higher cardiac output. This is the first part or the first technology of the thermodilution. And the second part, which is the analysis of the arterial waveform, or what we call the pulse contour analysis. And we will come to this in the next slide, how we are interpreting this technology. So basically, the monitor is very simple. We have a regular central line, any central line, and we have a special catheter, which is an arterial catheter. Mostly it's a femoral catheter. to be inserted in the femoral artery, and it's containing a special thermostat, and there is a certain calibration and certain connection here connected to the Pico monitor to get the readings. Basically, you have many different tools or different monitors for the Pico or the pulse control technology. We have two important or two main version, which is one of Germany, is a Pulsion, and the other technology, which is from USA, Edward Life Science. So we have the Pico monitor and the from Pulsion, and we have the AV1000 from Edward Life Science. This is the calibrated at what we call the calibrated pulse contour or cardiac output. We mention it as a calibrated because here we are using the two technology at the same time, the thermodilution and pulse contour analysis. If you are not using the thermodilution, you will have the non-calibrated or what we call, we like to call it semi-invasive, non-calibrated pulse contour. It depends here only on analyzing the arterial waveform by a catheter. And again, there is two different systems. For Edward, we have the flow track system. And for Pulsion, we have the ProAct. This is the same technology, the flow track and the ProAct. And here the Pico and AV1000 are the same technology. I work with both monitors. There is no any benefit from using any one, no superiority of one monitor over the other. They are getting the same data, same information from both monitor. But of course, I'm recommending using a calibrated monitor with the two different technology, the thermodilution with the pulse contour, rather than using the non-calibrated one. This is some photos for the monitors. This is the AV1000 monitor, and this is some of the Pico. This is old version, new version of Pico. This is how we can interpret, very important interpretation of the pulse contour analysis. And we have one important parameter here, which is the stroke volume variation, all the parts pressure variation. In this part of the analysis, we are depending on analyzing the arterial waveform, which we are usually seeing as a red color on our hemodynamic monitor, regular monitor. The stroke volume variation will appear like this. If you have the patient is dry or the patient is fluid responsive, we will have a big variation between the size of the different wave of the stroke volume. If you have too much variation like this, you are expecting to have a good response or a good fluid response. If all the waves are equal to each other, like these two waves, it means the variation is low, the patient will not be a fluid responsive. And of course, there is a cutoff value, which is around 13% variation. Any higher number more than 13, it means that the patient will be fluid responsive. Lower number less than 10%, it means that the patient will not be fluid responsive. And of course, the higher the number, the higher the possibility or the confidence that the patient is a fluid responder. It means if you have a patient more than 20% variation, definitely this, of course, patient will be a fluid responsive. Of course, you can understand that this variation is a normal physiological variation because this is happening with the respiratory cycle during inspiration and expiration. But there is exaggeration of the normal phenomena in the presence of hypovolemia. There is exaggeration of the normal phenomena, and there is significant difference in the stroke volume size. And this is, of course, reflected on the monitor, and it's an automated calculation. The monitor will come with a number, so you can know from the number if you can give more fluid or no. Of course, to apply this monitor, the patient should be ventilated, should be on the ventilator, should be one of the restriction of the or disadvantage of the monitor is the patient should be on a high tidal volume, at least 8 ml per kg, should be well sedated, no spontaneous breathing on the monitor. And because we are analyzing the arterial waveform, the patient should not have any form of arrhythmia. Patient in atrial fibrillation, you cannot apply this part of the analysis on them. You can apply the thermodilution, but you cannot apply the pulse contour parameters, especially the stroke volume variation and the pulse pressure variation. It's not applicable if the patient has arrhythmia. It's not applicable if the patient is not in a full sedation and good tidal volume more than 8 ml per kg. This is some of the summary of the important measures that we can take from the PICO. For the thermodilution parameter, is we can measure the cardiac output on the same principle we are doing on the Swan-Ganz, checking the cardiac output. You can check the global end diastolic volume. It's one of the volume reflecting the fluid status, but again, it's not one of the static, not the dynamic parameters. Intrathoracic blood volume, again, it's a static one, not very important. Extravascular lung water is very important. This is reflecting the amount of water in the lung. And of course, if you have high number, the normal value for extravascular lung water should be 3 to 7 ml per kg. If you have a higher value of higher than this number, you should expect that the lung is flooded, congested, and you should be very cautious giving fluid, even if the patient is fluid responsive. And you should balance your decision, especially if you have like patient with ARDS or pulmonary edema, you should balance your decision whether to give fluid or no, and to check the fluid responsive versus the fluid tolerance status. Pulse contour parameters, of course, will give us, again, continuous cardiac output, will give us the systemic vascular resistance, the afterload, will give us the stroke volume variation, which is the parameter of the preload, as you mentioned, the fluid responsiveness, the afterload, and the cardiac output, the 3 important parameters which we need to know about any patient. So as you mentioned, this is summary of the important data. Again, preload, to have stroke volume variation, pulse pressure variation for fluid responsiveness. Cardiac will have the stroke volume, cardiac output. Afterload, we have the SVR, systemic vascular resistance. For the lung, we will have the extravascular lung water. One question here, if you, I will ask you which one you will prefer to check, the stroke volume or the cardiac output. What do you think? Anyone have an answer? Which one you prefer?
Stroke volume is better.
Yes, why?
Heart rate I can calculate easily and I can change.
Yes, yeah, and you are very near to the answer, because the cardiac output will be easily changed with the heart rate. Heart rate is very variable. The heart rate can increase from 100 to 110 or 115 in a few seconds. This will reflect, will give us false impressions that the cardiac output is improving, while actually the contractility is not improving. The stroke volume will remain the same, but the cardiac output will increase. So to really assess the contractility, it's better to go with the stroke volume, because it's a direct reflection of the contractility. While the cardiac output, it's will be affected by change in the stroke volume and also by change in the heart rate. And as you know, in a critically ill patient or unstable patient, the heart rate is very variable. For any pain, any physiological derangement, the heart rate can be changed easily. This is example of the, this is real, one of my patients, real screen for PICO from one of the patient. You can see here, you can see all the parameters. And by the way, you can adjust the monitor as you wish. You can change the parameters here. You can put another parameters. You have many views, one of the volume, one for organ function, one for circulation, and so on. And you can decide which numbers to use. Basically, there is one important remark here. You will see some of the numbers coming like this, and some of the marker is coming with this mark. What is this mark? It's like a watch or a clock. What is this mark? What does it mean? Anyone have idea? Anyone have experience with PICO to answer this question? Just to save the time, this mark means this is all the parameters coming from the thermodilution will have this mark, this clock mark. All the parameters coming from the pulse contour analysis will not have this mark. Why? Because in the thermodilution, we are, as I told you, are giving cold injection, and we are checking the thermodilution curve, and all these parameters will come after doing this intervention. The thermodilution parameters are not minute-to-minute change. Unless you will have a new calibration, a new injection, you will not have a change. These numbers will be fixed, maybe for 8 hours, 12 hours, according to the protocol of your ICU. In general, in ICU, we are checking, doing the injections 3 times per day, every 8 hours. So all the parameters coming from the thermodilution will remain unchanged. until you have the next reading or the next calibration or next injection after 8 hours. So the number will change. The numbers coming from the pulse contour analysis, it will be variable. Every minute, every second, it will vary because it's dynamic. You are analyzing the arterial waveform and it's coming every minute, every second change, so the number will be changed. So if you compare here between the PC pulse contour cardiac index compared to the cardiac index here with the watch sign or the clock sign, you will find some difference because this is the one with the thermodilution, and this is the one with the pulse contour. During calibration, we are expecting that we will have almost the same number. During the calibration, the number will be the same, but after 1-2 hours from calibration, maybe the patient condition is changed, and you should follow the dynamic one, which is changing the PCCI and not the CI. By the way, the number in the monitor will be reflected as cardiac index, stroke volume index. And if you don't know the cardiac index, it's the cardiac output divided by the body surface area, which is in average adult patient, it's around 1.7. So we're expecting if the cardiac output in normal, we can say it's like 5 liter, the cardiac index is supposed to be like 3 liter because it's divided by 1.7. And again, if the stroke volume is 70, we're expecting that the stroke volume index normally should be around 50. What we can see here from this case, we can take it as an example to discuss or to explain more, that we have a very low cardiac index and we have a very low stroke volume index. You can see here that the affection in the stroke volume is much more obvious. Why? Again, because here the heart rate, here you can see the heart rate is 120. The heart rate is high. It's a little bit compensating for the cardiac index, which is not very low. It's low, but not very low. It's 2. But here the stroke volume is very, very, very low. So here we can check that the contractility, you have a problem in the contractility, or maybe we have a problem in the volume. We should decide here whether to give IV fluid to give volume or to increase the inotropic support. What we can notice here that the stroke volume, systemic vascular resistance index is 2000, which is almost in the normal value. By the way, the monitor will give you here the normal value for each parameter, so you will not bother yourself to remember the number. And you can see the normal value between 1700 and 2400. The systemic vascular resistance is accepted. It means that the patient will not benefit from giving any more norepinephrine or vasopressor. But you should decide to give fluid or to give inotropic agent. You can see here that the stroke volume variation and pulse pressure variation is very high. It's more than 25 and 28. This may be reflecting that this patient will benefit from giving fluid. This patient, according to these parameters, is a fluid responsive patient, but we are not sure if he will be a fluid tolerant patient or no, because you see here that the lung water is high. It should be maximum 7, here is 16. Maybe the lung is a little bit flooded, so you should consider the hemodynamic status, the perfusion, the lactic acid, and you should consider the oxygenation also, and you should balance the effect of giving fluid versus not giving in this situation. And even if you can go for quick analysis of the arterial waveform here, you will find that there is significant change. Even if you don't have a PICO monitor or just checking the arterial waveform on the monitor, you will find that there is significant change in the size of the waves, denoting that there is high variation in the stroke volume, and this patient is expected to be a fluid responsive patient. So to summarize the advantage of PICO, it's easy, automatic measurement, no bias in measurement, but the limitation, as I mentioned, it cannot be used in arrhythmia with low tidal volume less than 8 ml, with low lung compliance with spontaneous breathing, because it depends on the respiratory variation of the stroke volume, and respiratory variation will not be manifest without this condition. Time is running. I will try to go more fast because we have a lot to mention. Non-invasive monitor. Again, this is Edward monitor, clear sight. We have the invasive, the semi-invasive, and we have the non-invasive. This is a clear sight finger cuff. This is checking the same as the stroke volume variation, but here they are analyzing the pulse, the pulse oximetry wave, which is the plethysmography wave. They are checking again the variation in the size of this wave. And there is another monitor here, which is also the Masimo. They are checking the PVI or plethysmography variability index, which is the same as the stroke volume variation, and also a number more than 13% variation will denote the patient is responsive. I'm not focusing too much on this because all the studies mentioning that the validity of these devices in the critical ill patient is not well validated, and it's not recommended to use in the ICU, but can be used in the rapid response team for initial quick assessment, maybe of the patient can be fluid responsive or no, but they are not good tools in the ICU, should go with more invasive monitor. So another key point, the PICO monitor is a very useful tool for assessing the fluid responsiveness, the cardiac output after load lung water. If available, you monitor and you have no contraindication to use it. Next station is echo for VTI, stroke volume cardiac output. I will try to summarize how to measure the cardiac output by echo. It's not easy if you don't have any skills of echo, but if you have basic knowledge of the echo, how to use it, maybe you can apply it. It's not very complicated also. Basically, this is a parasternal long axis view of the echo view. And this is, of course, the left ventricle. This is the aorta, and this is the left ventricular outflow tract. This is the area where the volume, the stroke volume is delivered from the left ventricle towards the aorta. And you can understand the idea of calculation of the stroke volume here by considering this shape or this volume as a cylinder. And if you will go back to some mathematical rules we learned a long time ago in the school, that to calculate the volume of a cylinder, we should have the surface area of this circle on the base, and you should have calculated by the height or the length of the cylinder. This is the volume of the cylinder, which is the surface area multiplied by the height or the length. We have another equation for the height. The height also is equal if you can estimate the velocity of the blood or the fluid running inside the cylinder, which is the blood, of course, running. If you can estimate, we can have an integrated formula by integrating the volume with time, because the height is equal the volume multiplied by time. So we will have here, the equation will be like this: volume equal area multiplied by velocity time multiplied by time, and we have what we call the velocity time integral, or the VTI. So to simplify the equation and to understand more what we're calculating here, we are measuring the left ventricular outflow tract diameter. We are calculating the cross surface area from the left axis parasternal view. I will show you in the next slide how is the echo appearance of this calculation. And cross-section area, as you know, it's pi r square. We are measuring the diameter multiplied by 2 to get the radius square by pi, which is 3.14. And then we are measuring the LVOT, VTI, or velocity time integral, from the apical 4-chamber view. And we are multiplying the two numbers, the cross-sectional area, or the area of the base of the cylinder, multiplied by the VTI, which is the length or the height of the cylinder. So we are getting the stroke volume. This is the volume of the cylinder, or the stroke volume of blood, the amount of blood running in the cylinder at that time. And of course, if you have the stroke volume, you can calculate the cardiac output by calculating the stroke volume multiplied by the heart rate. So this is a very simple equation. But if I will ask you one simple question here, if I will give you a choice to choose only one parameter, you will prefer to use the cross-sectional area, the diameter of LVOT, or you will prefer to use the VTI, and why? Which one is more important? What do you think? Any answer?
VTI.
Why VTI? It's correct answer, but why VTI?
This is the time during systolic.
Oh, actually, the VTI it's a variable part of the equation, because the cross-sectional area of the heart will not be changed. The diameter of the heart will not be changed. But what will change if the patient you are giving any intervention, giving fluid or giving inotropes, the cardiac output will increase by increasing the velocity, the VTI, because the diameter will never be changed. So the VTI is actually what we need to measure in real practice. We are not measuring the cross-sectional area because it's fixed for the patient. And by the way, even it's more or less not very variable between one patient to the other. Most of the time is equal. The diameter is equal to centimeter in most of the patient. And in a certain patient, it will be fixed all the time. So the only variable is the VTI. And it's important to understand also in hemodynamic monitoring in general, we are not too much concerned about the number, but we are concerned about the trend. It means that I am not concerned about how much is the VTI, but I'm concerned about the progress of the VTI. If the VTI is 10 and I give a patient certain fluid challenge and the VTI now is 15 or 16, this is significant improvement in the cardiac output. The cardiac output is increasing. But if the patient VTI is 20 and now I'm measuring after 30 minutes is 16, it means that in this situation, the patient is deteriorating. So the 16 can be a sign of improvement and can be a sign of deterioration. So we are concerned about the trend, and we are measuring the VTI as a surrogate of the stroke volume, as a surrogate of the cardiac output. And it's important here to understand again that a 50% increase in the VTI is considered a good response, and it's one of the parameters to check for the fluid responsiveness. If you are giving fluid and the VTI increase by 15%, it means that the stroke volume and cardiac output is increasing and the patient is fluid responsive. And this is one of the important parameters. If you don't have a PICO monitor to check the response to fluid by, I mean the cardiac output, you can check the cardiac output through measuring the VTI. How to measure it? This is just for demonstration. This is the parasternal long axis view. This is the left ventricle. This is the aortic valve, the aorta. And here is the left ventricular outflow tract. This is the area we are measuring the volume here. This is the diameter we are supposed to measure, left ventricular outflow tract. We are zooming here to get more views. This is the aortic valve, and we are supposed to measure from the base of the valve to the base of the valve here. We are getting decreased depth and getting zooming, decrease the gain, and we are freezing the image. And then after freezing, you will measure during the diastole while the two cusps are open till the maximum opening, and you are measuring here from this part to this part. And as I told you, this measurement is not very important. It will not affect too much your decision, but just for academic purposes, I am showing you how to measure it if you want to get a real cardiac output measurement. But we are in practice, we are measuring the VTI. VTI, we are getting the VTI from the apical 4 or 5 chamber view. We are getting the aortic valve. This is the 5 chamber view. Here is the left ventricle, left atrium, and this is the aortic valve here. And we are applying the pulsed wave Doppler here at this point. Pulsed wave Doppler, you can see here, you can apply it like this. And you will apply the pulsed wave once again. You will have this envelope, and you are measuring this envelope. This is the velocity time integral. And as I told you, it's a relation integrated between the velocity and time. So it's reflecting a distance. So that's why the VTI will come to you as a measurement as a distance, 20 centimeters. That's why it can be incorporated in the equation of the volume as a length or the height of the cylinder. In general, for people who like the normal value, I don't like too much the idea of normal value. VTI, generally, it's between 17 and 25 centimeters. This is the normal value. But you should understand that every patient has his own normal. And the VTI, the most important is the trend. Is it increasing or decreasing, not the absolute value? Here, how you can see this is a 5-chamber view, and you can see the aortic valve very clear here. This is the left side of the heart. This is the right side. And you will apply the cursor of the pulsed wave Doppler here, and we will press again on the pulsed wave Doppler, and you will have this envelope, and you will measure it from baseline to the maximum and to baseline again, and you will have a reading of the VTI. So we can conclude here that the echocardiography is a very good tool to assess the cardiac output by checking the VTI, which is a direct reflection of the stroke volume. This is the last point, but it's a little bit long. I will try to summarize because we are a little bit late. It's very long now. I am sure they start to get exhausted and bored. I will try to go more fast. We'll have some clinical tests like the mini fluid challenge test. I will focus on the passive leg raising test and end expiratory, but I will start first with the IVC respiratory variation. A PICO monitor we already covered in the previous section, and you know about the stroke volume variation and pulse pressure variation now as a tool to predict fluid responsive. If it's more than 13% variation, the patient will be fluid responsive. This is one of my personal study in the hemodynamic. Was an MD thesis by our colleague, Dr. Mohammed Fawzi Khalil, and it's done in collaboration between Alexandria University and Cairo University. Our colleague from Cairo, Dr. Gamal Hamid, Dr. Mohammed Fikri, and Dr. Yasser Nassar, and myself representing Alexandria University, who are comparing different dynamic clinical tools in prediction of fluid responsiveness in shock. We compare between 6 different tools to check the fluid responsiveness. We did 2 clinical tests, passive leg raising test and end expiratory occlusion. We did the IVC, also respiratory variation, and we did from the PICO, we get the stroke volume variation and pulse pressure variation. And the aim of the study was to compare the effectiveness and accuracy of each of these parameters to predict the fluid responsive. And the result came that the best was the passive leg raising test, followed by the stroke volume variation, pulse pressure variation, and to less extent the IVC. And the least accurate was for us the end expiratory occlusion test and the variability of VTI, which were not significantly correlated. And this is the sensitivity and specificity of each item and the accuracy. And this was published in as an abstract in European Society, and it's published in the intensive care experimental as an abstract, and still the full article is still under publication. This is one of the personal study in this field. We did it with our colleague in Cairo. How to measure the IVC? Just to remember, important point that we are checking the IVC respiratory variation, not the diameter, because the IVC diameter has a poor predictive value as a static parameter. We are talking about the dynamic indices. We are talking about the respiratory variation. I will bypass these slides for the time. Just to compare here, this is how we will see the IVC through the acoustic window of the liver. We'll see the right atrium, and IVC will appear as a transverse tunnel like this. I will show you more videos. This is the right atrium IVC through the liver. Basically, the patient should lie supine. We'll go to the subcostal view. This is how we'll start the examination. You are applying the probe. You see subcostal with the indicator of the probe to the 3 o'clock to the left side. To see the subcostal view first, it will appear like this. I don't know how to. I think this video is not running. This is video. It's not clear. No problem. Then we rotate the probe 90 degrees, so the indicator of the probe will be directed cephalic towards the head like this. Video is not running also. Anyway, this is the picture of the IVC. It's very important here to recognize 2 things while checking the IVC. That part of the right atrium should be in direct connection with the IVC, and you can see this line. What is this line? Anyone expert in the ultrasound? What is this line?
Hepatic vein.
This is the hepatic vein. It's very important to recognize the hepatic vein for 2 reasons. Just to be sure that this is the IVC, it's not the aorta, because you can mistaken the IVC with the aorta. It's parallel to the IVC, but it's a little bit lower. So to be sure this is the IVC, you should get the hepatic vein. And it's an important landmark because you will take the measurement, the respiratory variation, you will take it by M mode. You should apply the M mode at this point. Just after the hepatic vein, you should apply the M mode at this point. So it's very important to determine where is the hepatic vein. What we are checking here, we are checking the respiratory variation by M mode. You can see here, this is the right atrium, the IVC, and the M mode is applied here. And you can see the respiratory variation between the inspiration and expiration. There is two different measurement. If the patient is spontaneously breathing, not on the ventilator, we are expecting that during inspiration, the IVC will collapse. So we will have what we call the collapsibility index for spontaneously breathing patient. While if the patient is on the ventilator, the reverse will happen due to the positive intrathoracic pressure. We are expecting a distensibility. The IVC will be distended more during inspiration. We will have the distensibility index. And of course, we have readings or numbers for each one. This is, again, right atrium IVC. You can see for spontaneously breathing with inspiration, the diameter will come smaller, while in positive pressure ventilation during inspiration, the diameter will be bigger. Don't bother yourself, because even in spontaneously breathing or in ventilation, you are not measuring, you are measuring from the M mode what is the maximum diameter and what is the minimum diameter, and this will be correlated with inspiration or expiration, whatever. But you should understand when you are interpreting this data that the collapsibility index in spontaneously breathing patients, the number should be very high, more than 40%, to have a prediction of the fluid responsiveness in spontaneously breathing patients should have a reading more than 40%, while the numbers on the ventilator for the distensibility, it's a lower number of 12 or 18% will predict the fluid responsiveness. There is two different equations here from different studies. You will see here the IVC variation, the maximum diameter minus the minimum diameter divided by the minimum diameter. If you will have a variation of more than 18%, it means that the patient will be fluid responsive. Here the equation is a little bit different. Maximum minus minimum divided by mean. Mean, it's a maximum plus minimum by 2. And here's the variation, it's only 12%. Just to summarize this point, to get it easy, of course, also for the patient on the ventilator, to get an accurate reading, the same restriction for the PICO is applied here. The patient should be well relaxed on a tidal volume more than 8, no spontaneously breathing. And if you have an IVC variation more than 20%, the patient is likely fluid responsive. If the IVC variation is very low, less than 10%, the patient likely will not be a fluid responsive. And in between 10 to 20, you will have a gray zone. You will not be sure the patient will respond or not. And all the new data, by the way, to be honest, regarding the IVC are not very promising. And there is a lot of question mark about the accuracy of the IVC to detect the fluid responsive. Still, we are using it as an easy, very easy tool. It's one of the easiest tools. If you don't have a PICO and you don't have enough skills, the IVC is very easy to learn. The learning curve is very easy. Anyone can learn the IVC. And still, it's give us some data. It's not very accurate, as mentioned in the new studies, but it's not difficult. If you see these videos, you can see very easy here. This is a normal IVC. Maybe this is a little bit distended, big diameter, and also the variability is very low. And here is very obvious that the patient is very low as the kissing. The two walls of the IVC are kissing each other, and the patient has a big respiratory variation. It's very obvious this patient, you can be very confident giving him fluid, while in this patient, you will not give fluid most of the time. Many limitations of the IVC measurement, it will be affected, of course, if there is high problem in the right side of the heart, if there is pulmonary hypertension, if there is tamponade, if you have any right-sided failure, patient on ARDS with poor lung compliance, if you have high intra-abdominal pressure, all these variables can affect the reading of the IVC. That's why, again, I am emphasizing that the IVC is not very accurate, but still you can follow the trend at least of the IVC. If you have an IVC like this, very small, very narrow, and you give the patient fluid and you start to have the IVC like this, you should be more cautious giving more fluid regarding the accuracy of IVC. This is one of the important, very important study published this year by Antoine Baron and Michel Slama, one of the eminent figures of the hemodynamics and echo. And they mention here, finally, that the IVC respiratory variation, while popular, cannot accurately predict fluid responsiveness. In a spontaneously breathing patient, collapsibility index depends on the level of inspiratory effort. And in mechanically ventilated patient, distensibility is only obtained in 78% of patients and has a poor predictive performance. This is one of the devastating or frustrating report about the measurement of the IVC. Actually, it's not the only one. As I told you, there is a lot of revision and new data regarding the accuracy of IVC, but still it's one of the tools you are using, but you should be cautious in interpreting the results. Passive leg raising test is very important and very easy test. I think most of you are aware about the principle. I will explain it very quickly. Initially, in the passive leg raising test, the patient should be sitting like this in 45 degrees, head up and leg flat. And then we will do a passive leg raising by putting the head of the bed flat and increasing the foot up to 45 degrees. The main idea that we are pushing or transferring the blood from the lower limb and the trunk towards the heart. And this is, we are simulating a fluid challenge. By doing this maneuver, around 300 ml of blood is mobilized from the trunk and the lower limb towards the heart. And this is simulating a fluid challenge, and we are expecting that the cardiac output will increase if the patient is fluid responsive. If the cardiac output will not increase, it means that the patient is not fluid responsive. This is the way how we are assessing the fluid response. The advantage, of course, of this test, it's reversible, because if you will give a fluid challenge, actual fluid challenge, and give normal saline, 500 saline or 300 saline, you will not be able to take it away from the patient if the patient is congested or if he is not responsive. But here, if you return the patient to his normal situation like this, the blood will go back from the heart to the lower limb and trunk, so you are not doing any overload on the heart and lung if the patient is not a real fluid responder. Some technical consideration while using the passive leg raising test. Of course, the angle should be accurate, 45 degree, using the bed adjustment and avoid touching the patient. Most of the ICU, you have the mobile beds. You can mobilize the head of the bed and the foot without touching the patient. The main point of not touching the patient, we don't like to affect the heart rate, because if the heart rate will increase, this can affect the cardiac output, and of course will affect the measurement. We will have a false increase in the cardiac output if the patient is in pain or awake. This will not reflect a real increase in the cardiac output. The main point now, or the main disadvantage while assessing the passive leg raising test, it should be directly measuring the cardiac output, not the blood pressure. So to apply the passive leg raising test, you should have a way to measure the cardiac output. You cannot rely to mention the patient is fluid responsive or no, only on the blood pressure improvement. You should have a real improvement or real increase in the cardiac output by 15%, and this is sometimes not applicable if you don't have a cardiac output. If you don't have no cardiac output or pico monitor, you should use the VTI. VTI, as I told you, is a good surrogate for the cardiac output. You should measure the VTI initially, doing the passive leg raising test, and then measuring the VTI again and check if there is change or no. Of course, because it's an operator-dependent measurement, it should be done by the same person. The same person should check the VTI initially, and then after the fluid challenge. Another point that you should wait to interpret the test by 15%, by 30 seconds to 1 minute. This is applied only for any fluid challenge or for PICO or anything. To get the response of on the cardiac output, you should wait 1 minute to check if there is real improvement or no. The improvement will not happen unless there is compromise or compensation in the body. So you should check the response after 1 minute to see if there is real improvement in the cardiac output or no. Using a real-time measurement of cardiac output is very important. You should reassess the cardiac output in the semi-recumbent position. You should return the patient back to this is the initial position. This is during the leg raising test. You should return the patient back and check if the cardiac output will go back to the normal value. This is the confirmatory part. And then you will give the volume. If the patient is fluid responsive, we'll give him the volume expansion. And this graph here represents this is increase in the aortic blood flows by measuring the VTI here. This is the baseline while the patient in the neutral position. During the passive leg raising, you can see there is significant increase from the baseline up to 30% increase in the cardiac output. And again, returning to the baseline, turning the patient to the neutral position, the cardiac output is reduced again. And here, after giving the real fluid challenge of 500 ml saline, you can see that the cardiac output increased significantly up to 50% after giving the fluid challenge. This is how you can use the passive leg raising test for interpretation. The main advantage that passive leg raising test can be used regardless of ventilation, can be used on mechanical ventilation, patient spontaneously breathing, regarding to the tidal volume, regardless. And also, if the patient has arrhythmia, you still have no problem to use the passive leg raising test. So it's very simple, bedside, easy test. The main disadvantage or the main difficulty, it's the point of that you should have a real measurement of the cardiac output. Easy, reversible in both spontaneously breathing, ventilated, applicable in arrhythmia. Main disadvantage is the real-time cardiac output measurement. So I will ask you a very important question because we are considering the different setting. If you don't have PICO monitor, which is the situation in many of our ICUs, if you don't have also enough scales or you don't have echo machine, you cannot measure the VTI. Is there any simple intervention you can use it as a surrogate of the cardiac output without using the PICO and the echo? This is a question for you. If you have any answer for this question, anyone can answer. Any simple tool which can predict the cardiac output?
Pulse pressure variability and end tidal CO2 variability.
This is very good. Pulse pressure variation you don't have if you don't have PICO monitor, but it's very easy to have the end tidal CO2. Excellent. Who answers this question?
Me.
What is the who is the I cannot.
Muhammad Raja.
أهلا وسهلا. Welcome, Dr. Muhammad.
Ah,
Thank you very much for this
thank you.
answer. This is very important answer. Actually, the capnogram is very easy. Every ICU, I think you can have a capnogram. You should connect it to the patient. And you can check the end tidal CO2. It's very easy to measure it. And again, if you have a 15% increase in the end tidal CO2, it means that the cardiac output is increasing because the end tidal CO2 is a surrogate of the cardiac output. It's very simple. If you don't have a very complicated tools, you don't have the echo, you don't have the PICO, you can use the passive leg raising test, which is a very simple test. Wait 1 minute and check if there is 15% increase in the tidal CO2. This means simply that the patient is fluid responsive and you can think about giving him fluids. This is a simple interpretation way for this test.
Sorry, because the pulse pressure variability is appearing on arterial line tracing.
Yeah,
So we
it's
can
appearing, but you cannot measure it. If you don't have a PICO monitor, you cannot analyze it as number. You can measure it as a percentage, how much variation?
I think it's now coming on in new monitors as a fixed parameter.
It's very good. If this is the idea of the PICO, the pulse contour analysis, is the idea that the monitor can analyze the difference, but I didn't see myself a monitor apart from the PICO monitor who can analyze the variation. If you have a monitor to analyze, this is the idea of PICO monitor. If you can analyze the pulse pressure variation of the volume pressure variation, and there is significant change, this is excellent.
But still, it have the same limitation, I think, of sedation and tidal volume and muscle paralysis.
I'm not sure because this is a different parameter. It's not a parameter of improvement of the cardiac output. Stroke volume variation and pulse pressure variation is an indicator of fluid responsive, but you cannot detect the patient cardiac output is increasing or no from this parameter. If you are applying the passive leg raising test, it's not enough to know if the patient cardiac output is really increasing or no. This is like a parallel test to the passive leg raising test, but not an end result review or a reference number to review through it. But the end tidal CO2, as you mentioned, is a good variable, a good solution for this problem. The last test is the end expiratory occlusion test. Welcome. The end expiratory occlusion test is a very simple test also. Patient on the ventilator, we are interpreting the mechanical ventilation at the end of expiration for 15 seconds, just pushing the bottom expiratory pause at the end of expiration, 15 seconds. This brief procedure supposed to increase the cardiac preload and the cardiac output. And again, as you know, if the cardiac output increase by 15%, this will definitely be interpreted as this patient is fluid responsive. Again, you have the same limitation. Of course, patient should be on the ventilated, well sedated, and also you should have a cardiac output monitor, or you have a VTI, or you have the end-tidal CO2 to interpret that the tidal volume is, that the cardiac output is increasing by 15% to categorize your patient as a fluid responder or non-responder. And this is how you can apply the test 15 seconds at the end of expiration, and you can check if there is increase in the cardiac output, the patient is fluid responsive. There is this new paper also published this year. There is actually more than one test now. They are talking about the end expiratory occlusion test and also about the tidal volume challenge and about the PEEP test. This is all are modification of this test to just to have more tools for predicting fluid responsiveness. I don't have time to explain all this, but I'm recommending also, I will give you in the last slide, recommendation or the references of many very interesting papers published all in 2024. If you are interested to read it, this is one of the important paper. I recommend everything to read it. This is by Xavier Monet, Daniel De Becker, and Michael Pniski, and the three are very well-known name in the hemodynamic field, and it's very nice paper actually. So to end this presentation, determining the intravascular volume and fluid responsiveness is a very difficult situation and somewhat and not something we always do well. Between the hypervolemia and the hypovolemia, it's very difficult to balance this decision. And many times you are not doing it in the proper way. You should use all the possible tools and all the possible facilities to reach the right decision. Hemodynamic monitoring tools. No monitoring device will improve outcome unless coupled to a treatment which improve outcome. You should monitor your patient. As I told you, it's a very dynamic process. You should do a certain intervention treatment which will improve the outcome. Only monitoring without intervention, of course, will not help too much. Just to revise the key points of the whole presentation, hemodynamic monitoring is a dynamic process depending on the balance between delivery and consumption. Determinant of oxygen delivery are cardiac output, saturation, and hemoglobin. Measure to reduce oxygen consumption, mechanical ventilation, sedation, muscle relaxant, cooling. Evidence-based medicine, the guidelines recommending to use advanced hemodynamic monitoring for fluid responsiveness using the dynamic rather than the static measures, using the echo, ultrasound, PICO, passive leg raising test, and others. PICO monitor is very useful tool for assessing fluid responsiveness, cardiac output after load, and lung water, if available and no contraindication, and you are aware about the contraindications, the arrhythmia, and if the patient is not on a tidal volume more than 8 ml. Echocardiography is a very useful tool also and a good tool to measure the VTI and to estimate the stroke volume and derive the cardiac output from this. Fluid responsive is an important and critical decision, can be assessed by many tools like the passive leg raising test and expiratory occlusion, the variation in the IVC by ultrasound, stroke volume variation, pulse pressure variation. The choice depends on the availability of tools and the experience of the operator. You should make your decision according to the available tools, but still, if you don't have tools, as I told you, a test like the passive leg raising test in the presence of a capnogram, I think it's not something difficult to have in any basic ICU. Combining more than one tool in hemodynamic management will be very helpful in optimizing your decision for critically ill shocked patient. I finish at this point. Just I have two things more to add for you. This is suggested reference and suggesting reading. This is seven or 8, I'm not sure, 7 papers, all published in 2024. Please, if you are interested in the hemodynamics, to take a photo for this slide and try to reach to get an access to read this paper about the fluid responsiveness, monitoring cardiac output, role of echo to predict fluid responsiveness, use of ventilator to predict fluid responsiveness. Very interesting, very updated data. I try to take some of the points from this presentation to during my presentation, just to but to read it in details. Of course, it will be very helpful. This is for suggested reading. Last point, I want to announce that we will have in UAE in next February an advanced hemodynamic workshop. I have the privilege and honor to be the course director of this hemodynamic workshop. It will be 13-14 February in the TDC, Training and Development Center in Sharjah in UAE. The course faculty will have 10 experts from many places. We'll have from France, Jean-Louis Touboul and Olfa Hamzawi from France. And we'll have from Saudi Arabia, Yasser Tolba, Ahmad Madi, and from UAE, we'll have Dr. Ahmad Taha, Jihad Malat from Cleveland Clinic, Abu Dhabi, Ahmad Tariq from Dubai, and Ahmad Ali from Ajman, Jalal Abdelnabi, and myself from EHS in Qasimi Hospital. We'll have a 2 days full day course. We'll have a lot of lectures, interactive session. We'll have a simulator for the PICO. We'll have hands-on session training about measurements, IVC and the VTI by ECHO. It will be a very comprehensive workshop for full 2 days. I'm encouraging everyone who can attend to come to attend the hemodynamic workshop 13-14 February. And thank you very much. I know we are very late, but if you have any question or any comments, I am ready for any discussion if you have any points. Thank you very much.
There will be access, online access for this
Yeah,
workshop?
there is a registration, of course, link registration. If you cannot reach it, just can send me any email or WhatsApp or anything, and I can send to you. You will find it. If you write the name of the conference, you will find there is access for registration and for registration for the workshop. Yes.
Not only registration, attending online, I'm asking.
No, it will be, unfortunately, it will be only physical because there is a
Physical,
lot of hands-on. Yeah, there is no online access, unfortunately, for the workshop. It's only physical attendance. Yeah.
Thank you.
Thank you so much, Dr. Amr. Thank you for your effort and your comprehensive and fascinating lecture. Really, it is a reference for hemodynamic monitoring. Thank you for all attendees. Really, today you have big vans, Dr. Amr.
Thank you very much.
We have 3 written questions, and if any of our colleagues from the floor want to ask Dr. Amr, so be ready, please. Some of our colleagues ask about the level of hemoglobin 10. Does it work in sepsis, cardiogenic, all types of shock, or only for cardiogenic and hemorrhagic shock?
Definitely for all kinds of shock. If you have a problem in the oxygen delivery, you should maximize the hemoglobin to the maximum 9, between 9 and 10, and don't go below 9. 9 is accepted, up to 10 is okay, because this is one of the factors of the oxygen delivery. If you have any kind of shock, you will have a problem in the oxygen delivery, and this will help to maximize or to optimize the oxygen delivery. Of course, all kind of shock, you should keep the hemoglobin around 10.
Yes, we have also 3 of our colleagues ask about the role of capnography in assessment of cardiac output. So just revise again, please.
Yes, capnography is a surrogate of the cardiac output. If you remember, if you are doing during the CPR, if you have the end-tidal CO2 increasing, it means that the circulation is already back, because it's a reflection of the cardiac output. Whenever you will have a good cardiac output, the end-tidal CO2 will improve. So the end-tidal CO2 by capnography is a surrogate, is an indicator of the improvement of the cardiac output. If you have any number like 30, 35, and this number increased by more than 15%, it's a real indicator that the cardiac output increased by the same percentage. But it's a very simple tool, because I know not all of people, they have the PICO monitor, not all they have an echo, or they have enough skills to measure the VTI. So it's a very simple way to detect or to be sure that the cardiac output is increasing. And the capnogram, I think, is available in all of our ICU. By the way, there is one paper here. I did not mention anything because of the time about this one by our friend Dr. Jihad Malat in Cleveland Clinic. Changes in central venous to arterial PCO2 difference and central venous saturation difference as a marker to define fluid responsiveness. And this, it's a very nice paper, just published 1 month ago. And they are using here the the PCO2 difference between the artery and vein before and after giving the fluid challenge to assess the response to fluid. And this, it's need to be, and it's difficult to explain it now. It needs some time, but it's very interesting. And it can be a good replacement if you don't have all the tools. You can rely on certain laboratory value like the central venous oxygen saturation and the CO2 gap, which is the difference between the arterial and venous system, to be an indicator again for the cardiac output or for the response to fluid challenge or the fluid responsiveness by a simple laboratory values like this.
Thank you, Dr. Amr. Anyone of the floor wanted
Thank
to ask?
you, Dr. Amr, for this comprehensive lecture. Really, it's very informative.
Thank you very much, Dr. Amr.
Dr. Amr,
Thank
thank
you.
you
I will
for
just,
your
I want
amazing.
to, بعد إذنك دكتورة صفاء, I want to announce that the lecture, it will be uploaded on our channel, inshallah, of the society channel in the YouTube. It's recorded and it will be, inshallah, صدقة جارية, inshallah, وعلم ينتفع به بإذن الله.
إن شاء الله إن شاء الله.
Thank you, Dr. Amr, for amazing lecture. I wanted to ask if there is any limitation for stroke volume variation in cases of obstructive shock like massive pulmonary embolism or cardiac tamponading. So I think there will be some limitation in stroke volume variation.
In cardiac tamponade,
Yes,
obstructive shock.
obstructive shock in general in massive pulmonary embolism or stroke volume variation. Can we
No.
depend?
Yes,
Same.
you can rely because this is no limitation, no limitation. This will reflect if you will give fluid, this will change or no. I think there is no restriction. Yes, it's still reliable. Yeah.
Thank you.
Yes, some of our colleagues ask about the channel. It is the ISAC channel, the Egyptian Society of Anesthesiology and Acute Care channel. Okay, this is the channel. Mostly on maybe tomorrow or after tomorrow, you will have this lecture recorded on ISAC channel, YouTube channel. Finally, it was a comprehensive and fascinating lecture. And as you mentioned, Dr. Amr, that fluid is a drug. The time to rethink about the fluid management, especially for our critically ill patient who will be benefit from this fluid, when to infuse this fluid, which type of fluid you will infuse, the route of fluid you will infuse, and the amount, of course. So again, fluid is a drug.
Sure.
Yes, and the variable methods of measurement you mentioned, Dr. Amr, in your lecture is very beneficial. How to monitor, even clinically, how to monitor, how to protect that this patient will get benefit from the fluid infusion. Many methods Dr. Amr mentioned about optimizing the hemodynamic of your patient, either in emergency department, in critical care unit, in OR. So please rethink again about the close monitoring of your patient, either clinically or using a machine or an instrument. Thank you for all my attendees. Thank you for Professor Muhammad Ahmed. He was our guest of honor today, and many of our colleagues. Thank you for Ahmed Fatin for joining us. Dr. Muhammad, دكتور محمد احمد.
ايوه دكتورة صفاء، ازي حضرتك؟
السلام عليكم. السلام عليكم.
عليكم السلام. Thank you for you and thank you for Dr. Amr for this very informative, great lecture.
Thank you, Dr. Muhammad. It's my pleasure and honor that you are attending with me today. Dr. Muhammad is one of my favorite friends and my brother, by the way.
He is our role model and great mentor, Dr. Muhammad, and he has very supportive for ISAC learning program, either the physical, the conference, the workshop, and also online. I have delivered many beneficial lecture for my colleague here in Egypt.
Definitely. Thank you, Dr. Thank you.
Thank you so much. Thank you. فاينلي كل الشكر والتقدير والتحية للدكتور أحمد القرش نقيب أطباء المنوفية، لأنه ده يوم أجازة في النقابة، وهو بيفتحوا النقابة عشان إحنا مخصوص to deliver our online program. وبهني كل زمايلي وزميلاتي وكل الجروبس ختام العام الرابع للاونلاين بروجرام. ان شاء الله يستمر لسنوات وسنوات ان شاء الله بوجود كل المخلصين، وان شاء الله دايما ما نتحرمش من كل السبيكر اللي هم بيفيدونا وبيعملوا لنا ابديت وبيخلونا to rethink again how to manage our patient. وبشكركم جميعا، وبشكر تاني استاذ الدكتور احمد القرش نقيب اطباء المنوفيه، وبشكر حضرتك يا دكتور عمرو تشريفك ليا النهارده، وارجو ان
شكرا
كل سنه
جزيلا.
بس طلب
شكرا
بسيط،
لحضرتك وانا شرف
كل
ليا.
كل سنه 10 محاضرات بس يا دكتور عمرو، مش عايزين منك اكتر من كده.
تحت
ويبقى
امرك والله،
شكرا
مفيش
جزيلا.
مشكله. تحت امرك.
دكتور محمد احمد، انا منتظر حضرتك تبعت لي هتقول ايه ان شاء الله في يناير باذن الله، واختار
إن
اليوم اللي
شاء
حضرتك
الله.
عاوزه ان شاء
إن
الله.
شاء الله.
ان شاء
بإذن
الله.
الله. إن شاء
شكرا
الله.
جزيلا، شكرا جزيلا لكم جميعا، وعام سعيد وطيبا لنا كلنا، وكل الصحه والسعاده والخير يا رب. شكرا جزيلا.
شكرا
سلام عليكم.
جزيلا لحضرتك.
السلام
عليكم
عليكم.
السلام ورحمه الله
السلام
وبركاته.
عليكم. السلام
عليكم
عليكم.
نايس.
السلام عليكم، مع السلامة.
مع السلامه.
عليكم السلام ورحمه الله وبركاته. عليكم السلام.